Bismillah ar-Rahman ar-Rahim. I hope that everyone is enjoying. I think there was one lecture before we start. I hope that you enjoy it as well. Today, inshallah, we can start as requested about rapid reporting. And I can show you some cases in this issue. Rapid reporting is part of exam 2B, as you know, and it is one of the most difficult parts of the 2B exam. And for the people who would like to, the candidates who would like to join the European diploma exam, also it will be beneficial to train yourself, as it is good for the short type of questions. So let's start just something like review, and after that I will show you some more examples. So this case, if you would like to comment, I will wait you in the chat. So this calcifications. Yeah. So yeah. So the many suggestion, and one of the good suggestion of you to think about the peritoneal calcification, or also the mesenteric lymphadenopathy. Yes. Also mesenteric calcified lymph nodes. So this one is good example for mesenteric lymph nodes. It can be calcified like this. Yes. Then you can think about TB. Perfect. Here, what takes your eye? First impression, you will mention what? There is small bowel dilatation, so small bowel obstruction, and yes, this one. So there is calcification in the right side of the abdomen, so you will think that it can be gallstone ileus. So this is a good differential for this case. And actually this case was calcified mesenteric lymph node as well. And the obstruction of this case surprised that it was cecal tumor. But I mean the approach is good approach that you think about gallstone ileus. So it's good for you, and also for the patient to mention the best or the most worst differential diagnosis. But in this case was a cecal tumor, which is not easy to detect here, but at least you suggest good approach. This one is more easy, something in the right hypochondrium and calcified, so it will be gallstone, calcified gallstones. So it is one easy one, yes. Again, right hypochondrial calcifications, so you are talking about calcified gallstones. Then this one is very typical for the exams, spot diagnosis. Yes, calcific pancreatitis, pancreas retroperitoneal. So when you find retroperitoneal calcification, you are talking about pancreatic calcifications. Exactly. And you suspect that this patient had before chronic pancreatitis. Again calcified pancreatitis, pancreatic calcifications from chronic pancreatitis. Here is much more easy to detect that there is a renal calculus. And after you inject the IVB, you can see it as renal defect. Dr. Ahmed, yes, Rabab, mashallah. I see the answers, very nice. And here, you can easily detect that there is staghorn stone, calculus, and there is another smaller in the other side. So bilateral staghorn stones. Okay. One of the important for spotting, bilateral nephrocalcinosis, medullary. Okay. So bilateral nephrocalcinosis. This one, sometimes it can be easy, sometimes it can be difficult. Yes, so there is right ureteric calculus here, exactly here. And you can see now how it looks. So ureteric obstruction. And this is like very common scenario that there is holding of the contrast. As you see, until a point, this point is the ureteric calculus after you take the IVB. So this is the ureteric calculus here, and the dilatation and the calyceal dilatation with clubbed calyces. Okay, just a review before I show you the checklist. And any calculus projecting over the bladder could be bladder stones, as in here. So common calcification in the abdomen. Again, this is urinary bladder stone, and this is multiple philibuli. Dr. Ahmed Divan, thank you for sharing. And bladder stone have many shapes. Sometimes it can give you a familiar shape of something in your life, anyway, or maybe something you eat. Bladder wall calcification. It can be also, but it's an uncommon finding. And then the discussion with you will be about the possible causes of the bladder wall calcification, like infection, or yes, schistosomiosis, yes, schistosoma, and infection, neoplasm, and or drug-related neoplasm. One of the commonest in the exam that he can present to show you the present you a picture to show you the adrenal calcifications. And then the discussion with you will be about possible causes. Again, it will be TB, previous TB, or adrenal hemorrhage. And also you can involve some diseases like Wolman disease. Yes, thank you. Yeah, Wolman, yeah, okay. We mentioned it before. And here just, I wanna, before I show you the answer, if you find any vascular calcification with curvilinear appearance, yes, aneurysm, until proved otherwise. So don't forget this curvilinear outline. Aneurysmal aortic dilatation, because it's critical. Very important to check if there is any calcified aneurysmal wall. So aneurysmal wall or abdominal calcification, aneurysm is one of the important checklist in the exam. Yes, abdominal aortic aneurysm. This one is very easy. Calcification in the pelvis. Fibroid, Abbas, Ala, Ivan. No, Ivan. Okay, so calcified uterine, and this is philibuli. Okay, Ahmed, yes. It could be, yeah, one of the differential urinary bladder. Yeah, I will show you even what you want to. It will come. Okay. So what do you think about here? This one, yeah, right iliac fossa calcification. The first possibility it could be appendiculith. And what about this? Do you have any? Yeah, it could be inside the bone, but to be honest, yeah, but right iliac fossa, and with this density, you can think about appendiculith also, especially if you find any obstruction. So appendiculith, and this one, calcified mesenteric lymph nodes, could be. Is not just one diagnosis, but you can think to check for appendiculith. And this even what you are searching for. So what is this? Yes, tooth in the pelvis is very important in the exam to see and to check for dermoid cyst. Yes, dermoid cyst tooth, containing tooth. Okay. So now the time to show you the checklist. Let's just see. Yeah. So you should, when you are commenting about the rapid reporting, you should in your mind to check for this. So you have in your mind the gases, and you have the bones, and you have the soft tissues, and you have the calcification. So actually, I show you some calcification, which is the most commonest calcifications, but still you have the air, and you still have the bone, and you still have the soft tissue. So the calcification, you already, like, don't forget the appendiculith and stones and aneurysm and so on. Okay, let's go to another checklist in the abdomen. So actually, the most important for you, it will be the emergency. So the acute condition in the abdomen. So starting from peritoneum. So you check air under diaphragm, as in here, and you can see that there is free air. So this is the most important. Sometimes it can be very subtle, as in here. So very subtle minimal air, free gas, again pneumoperitoneum, and what is this? So this is the difference between double wall sign or what is called Rigler sign. Rigler sign that you should be, you have the wall visible from both sides. So this is a true Rigler sign that indicate that this patient have pneumoperitoneum. So double wall sign. But this is one is normal, which is pseudo one, pseudo Rigler sign. Mashi? Okay. So here, double wall sign. So there is a free gas. And here is much more easy to detect what is called football sign, as you see. Yeah, football, Dr. Ahmed, yes, football sign. And one of the most important to check the liver edges. The liver edge, at the edge of the liver, you can see rim of gas, outlining the liver. Okay. This is a normal. So this is the normal that you see the thick wall of diaphragm, and you can see the bubble of the stomach. So this is a normal one. So what is this? Gas with insinuated. So yeah, Chilaiditi syndrome. Yeah, you know Chilaiditi, everyone know it. Chilaiditi phenomena. So this is also can be like a normal. You can consider it as normal. There is risky perforation. So this one is false Rigler sign. Yeah, again, it's false because it give you like pseudo impression that there is gas, but there is no gas in the abdomen. And here also it can be sometimes tricky for you to think that it could be pneumoperitoneum, but it's not, because this one is the perirenal fat, which is retroperitoneum, and this one is the peritoneal fat itself, and this one is the abdominal wall fat. So this is 3 layers. Sometimes the good clue there that you compare it with what? Compare it with the true air. Air, for example, in any lumen or any bowel lumen. So you can compare both and see if it is a free air or not. Here, before I show you the answer, you can say that there is dilated bowel loops, small bowel loops, and you can see the valvulae. So it is a small bowel obstruction, Ahmed, perfect. And you will search for any clue. Here the clue was very subtle anastomotic sutures that indicate that this patient have surgery, and now this is the cause that it have adhesive type, exactly. You know already that if you measure and you find it more than 3 centimeters, so it is dilatation. Here again, you will search for the cause of the ileus. You can see that there is small bowel dilatation in the abdomen more centrally. And if you can see that there is surgical wound here, very subtle. So this patient have again the adhesive type. This patient have cesarean section, which is a common site for cesarean section here. Okay. It's not easy. There is one thing called like isolated or sentinel loop. Like you can see localized bowel dilatation. And this can come with, yes, with pancreatitis, acute pancreatitis, sentinel loop with acute pancreatitis. Large bowel obstruction, if you find the dilatation in the cecum more than 9 or the other segment of the colon more than 6 centimeters. If you find this dilatation, you will search for the cause. For example, here, there was like soft tissue mass here, which is not easy. But you can imagine that there is something here. So this one wasn't absolute obstruction because you can see the rectal air here. There is the most important spotting in the abdomen, how you differentiate or how you mention at least the sigmoid or the cecal volvulus. So this one sigmoid volvulus, And you can imagine that the site of twisting of the mesentery, it should be in the left iliac fossa here. And this is what is called the coffee bean sign. And here you can see that there is proximal bowel, the colonic dilatation here. And this one is the cecal volvulus. So if you go and check the right iliac fossa, you will find that there is massive dilatation of the cecum. So this okay. We were talking about the rapid reporting, and one of the important issues for the FRCR or EDIR short cases that you should recognize the acute conditions, especially in the abdomen and the gases and so on. So one of the important signs, the thumbprinting, and you can think about ulcerative colitis or any types of colitis. If you find also this, what is called this sign, yes, Dr. Abab, lead pipe colon, loss of the normal haustra. And here, what happened? There is complication, which is toxic megacolon, dilatation of the colon, very dilated, and this patient probably he have known history of ulcerative colitis, which is common complication for the ulcerative people. Okay, so we finish like short review about the gases. Let's have another review about the soft tissue. Then we can go to the exam. Just a moment. Yes, this one. So let's see this one. Yeah, one of the most important checklist I will show you again that you check for the soft tissues. So you check for psoas muscles. You check for the sides of the abdomen. You check for any displaced bowel loops. You check for abdominal hematoma, and if there is any situs. So for example here, what is the abnormality? The abnormality is there is, at least you can say that there is pleural effusion and there is some dilatation in the colon. So pleural effusion and dilated colon. Okay. ماشي. Okay. The abnormality here. Yeah, so there is displaced bowel loop, one of the important checklists that you check for displaced bowel loops. So could be hepatomegaly, could be pelvic mass, could be renal mass. So check and tell me which one you will choose. So it will be liver lesion, exactly. Ahmed, yes. And the bowel displaced. Perfect. So again, another example. There is some displacement of the bowel loops, soft tissue thermotraction here, and probably here. So there is probably hepatosplenomegaly. That's the case. There is hepatosplenomegaly. So they are pushing the bowel. Yes. So some bowel is insinuated here, some bowel are here. Perfect. And here. Yes. Yeah. So this is the kidney. You can see the kidney here. And probably the right kidney here. So there is some enlargement of the kidneys. So you ask yourself if this patient have family history of polycystic kidney disease. So yeah, and the thing that you are thinking here, why the bowel is not displaced, because the kidney are retroperitoneal structures. Yes, the bowel not displaced because the kidneys are retroperitoneal structure. So you can see that the bowel itself in the same side. Yes, no displacement. Okay. So what here? What is here? So the bowel loop here is located, the stomach and the bowel loops is located centrally. Abbas, perfect Abbas. So you will think about ascites. Free fluid and the solid organs have the similar densities. The central location of the bowel, characteristic. And if you look in the abdomen itself, it's like there is hazy density. So this is the characteristic of ascites. Okay. There is just I want to mute someone who have something in the mic. Yes, Dr. Muhammad, thank you. So what do you think about this one? So this is the bowel loops. So the displacement here in which direction? Upward, yeah, upward. So there is pelvic mass. Perfect. Yeah, I mean, you can think about large fibroid or any pelvic mass. It can cause this appearance. So pelvic mass. Perfect. Upward. So it will be pelvic mass. Okay. To be honest, the transverse colon, it can be mobile because you know the transverse is like yeah, it can be transverse and sigmoid. They can be mobile, is not fixed, so they can be movable. But the issue that there is something here. It's subtle. Pelvic mass, small. Yeah. Small pelvic mass. Perfect. Yeah, the answer is pelvic mass and the small. Yeah. Pelvic small mass. Finally, you have patients with multiple issues, especially degenerative spine disease, osteophytes, maybe some sacroiliitis, mild, and there is osteoarthritis, and this patient already have fixation. So this is what is called distraction. So you are distracted now by many issues, but the acute condition here will be, yeah, pubic fracture here. Yes. So you are distracted by multiple issues in the film. The most important to see the acute condition for the exam and for the practice also. So this is the acute condition, acute pelvic fracture in the right superior pubic bone. Perfect. Ivan, nice. Yeah. So what do you think about here? Yeah, sclerotic metastasis, multiple, numerous sclerotic lesions all over. If this patient, if he is male, you'll think about prostate. If female, you'll think about breast. Exactly. This one, I would like to hide the answer to see what do you think. Yeah, is Paget. Cortical thickening with broadening of the bone, trabecular thickening of the bone. So you are talking about Paget disease. So bone expansion, coarsening of trabeculae. So this is like one of the commonest checklists in the commonest finding, a checklist of the abdomen in the soft tissue. So this is what is called the abdominal radiograph checklist. We talk about the soft tissue, and time to talk about, we already talk about the calcifications. Okay, let's shift another review. Sorry. So time to detect some, like here, to detect something different. Yeah, probably there is nothing here, just there is something there. So what is this? Yeah, anastomotic suture, perfect. It is here, yes. So just this patient have operation before, so iatrogenic artifact. So you refer to the history to check if this patient have any surgery. This one is very important to know. This is what is called colonic stent. And what is the importance of this? To check for or to relieve the obstruction. So this important for relieving the obstruction. If this patient have before large bowel obstruction, they put this colonic stent before until they can plan for elective surgery. So this is the colonic stent. Okay. What it is? Who have knowledge of intervention, it will be easy for him. Yes, feeding tube, gastrostomy tube, exactly. So this is the stomach, and this is what is called internal bumper. And here you can see this triangle, which is external bumper, and this is the gastrostomy tube. Yes. This one is easy, outside, and you insert in the kidney. So it is nephrostomy tube. Yes, Ahmed, thank you. More easy one, urinary bladder cancer, catheter. Catheter in the urinary bladder. Yes. What is this? Again, yeah, catheter, stone with suprapubic catheter, cystostomy. He put like suprapubic catheter to relieve the obstruction. This patient cannot be catheterized from down, so they make like suprapubic relief. And here, what you have here, you remember what when you find any curvilinear, yeah, so this abdominal aortic aneurysm and treated by EVAR stent, endovascular aneurysm repair. And also here you can note that there is stent in the left renal artery and in the right renal artery as well. Aortic aneurysm, EVAR. So, surgical sutures. And what it is? Colostomy. Yeah, so this is the stoma. So previous colostomy, ileostomy, urostomy. Does this patient have? He did operation for the urinary bladder resection, and they make what is called urostomy. So this is what is called stomacular artifact. Stoma artifact. Here for urostomy. You should be aware of this. Yes. Swallowed or inhaled. What do you think? Is it in the esophagus or in the stomach? This is the very important exam question. How to differentiate between both? Is it in the esophagus or in the trachea? So it is ingested. Yeah. Why? The coin is wider than the trachea, and so it is not being inhaled. It should be in the upper esophagus. Okay? So it is in the upper esophagus. And here in the lateral, you can see that the trachea, so this one is behind the trachea. So it is in the esophagus. The coin is here. Then he entered with the endoscope in the esophagus and remove the coin outside, and successfully the patient in good condition. Okay, this one, this is for the females when, yes, ingested needle, sometimes incidentally happen. Yeah, it can be for the needle foreign body. Yeah, ingested for the stomach. So ingested needle, the accidentally when you're making your hijab, for example, you can take it and okay, whatever the details, this is the needle ingested in the beyond the gastroesophageal junction. So another needle, can you remove this blue line? Another, what is the annotation? Yeah, here to remove. Is it removed or clear? Yeah, clear all. Okay. So needle foreign body, again ingested. This patient have mild abdominal pain. So needle foreign body. Exactly. This patient will follow up by erect chest X-ray. Right. Why? To check for perforation. Yeah. So this patient will do many X-rays until this needle goes safely, busts safely, and with no perforation. So the fear here can be perforation. So what to do? He will do many X-rays, abdominal X-rays or erect chest X-ray to check any signs of perforation. Okay. Again, another type of ingested artifact. This was razor. And again, you will check for any signs of perforation. Here, there is nail. And hopefully, there is no perforation, no free air. So, yeah, nail. And there is no free air. The most important to mention that there is no free air. Exactly. So this patient have fixation, and there is in the colon, there is material. So what it could be? Residual barium. Perfect. Yes, residual barium. So this is one of the most famous artifacts. And here there is some situation that is not just for the practice, maybe that in the airport, some people can hide something like this, which is not easy. I don't know how, but yeah, like this. One of the nightmares. Anyway, this one is what? Bissary, yeah, for Ahmad, yeah, prolapse. This is for uterine prolapse. Yes. So this one for uterine prolapse. Exactly. And here, this one, what is this? So this is what is called tampon artifact. And here in the right hypochondrium, you check for gallbladder surgical clips, cholecystectomy clips. And here, IUCD. So there is intrauterine contraceptive device. Sterilization clips for the ligation of the tubes, fallopian tubes, sterilization clips. So time for the exam. Let's have a look how it can work when you go to the real exam. Stop the review. Just before I will go to show you some real cases, I want to just show you this one. Like diagram, how you can check for the checklist. So check for the vertebral body and draw in your mind that you have this appearance in every vertebrae. Then when you go up, you check for the ribs one by one. If any lesion or any fracture, then you go to check the bones, sacroiliac and the sacral foramina. Check for the outline of the bones. Okay. Calcifications, we already mentioned them. We check for renal calcification, ureteric calculus, uterine fibroid, bladder calculus, appendiculate, gallstones, porcelain gallbladder, and the curvilinear one, abdominal aortic aneurysm. For the bowel, you check for any volvulus, large bowel obstruction. The most important three: sigmoid, cecal, and large bowel obstruction. Any thumbprinting, colitis, any mural gas, and the small bowel obstruction. Finally, so you check with bones, calcification, bowel, and finally you go to the gases. The places of gases, branching pattern of the gas in the biliary portal system. Morrison pouch free gas in the subhepatic space. Don't forget regular sign and pseudo-regular sign to check both sides of the bowel. Triangle sign, the same concept as regular sign. Let's go for some cases. The sign here is continuous diaphragmatic sign, indicate that this patient have pneumoperitoneum. This one have true regular sign, both sides of the with free air, and Cupola sign. So you are talking about pneumoperitoneum. Here, this is what is called Cupola sign. Again, pneumoperitoneum, continuous diaphragmatic sign with true regular sign, Cupola sign, minimal free air, pneumoperitoneum. The difference between the true regular sign and the normal. Triangle of gas, pneumoperitoneum. Very subtle triangle of gas, pneumoperitoneum. Again, you know this, we mentioned it before, inverted sign along the lateral umbilical ligaments. So free air along the lateral umbilical ligament. Again, pneumoperitoneum. Urachus sign, free air surrounding the urachus. So this is what is called urachal sign. Retroperitoneum, so pneumoretroperitoneum outlining the kidneys in the perirenal retroperitoneal fat. So you are going with the retroperitoneal air, free air. Again, don't forget continuous diaphragmatic sign, Cupola sign with double bubble sign, Copula for pneumoperitoneum. Lesser sac gas. Cupola sign again. Triangle sign. Free air. This is abscess gas. Football sign. Falciform sign. Ligamentum teres sign. Free air along ligamentum teres. It show you very perfectly when it's surrounded by air. Subhepatic free gas. This is the normal fat. This is the abnormal air. Compare it with the other air, you will find that similar density. Decubitus for free air. And there is a free fluid. Again, Rigler sign, both sides of the bowel abdomen. Air anterior to the liver. Free gas. Morrison pouch. Free gas triangle sign. Air under diaphragm with this appearance. I show you this. Okay. So now you have bones, soft tissue, calcifications, gases. You have four points checklist. And tell me what do you think? Yeah, but check for the bowel itself. Is it dilated? Small bowel? What do you think? So check for the gas first. Yeah, so there is dilatation of the small bowel. So bowel obstruction. Pediatric patient. No gases, just you have these two gases. So easy one. Double bubble sign, indicating duodenal obstruction or atresia. Intussusception. Perfect, Ahmed. Huda. Bowel dilatation. So there is bowel obstruction. Yes. Proximal bowel obstruction, jejunum along the proximal bowel, perfect. Pediatric patient, high obstruction or low? High. Small bowel obstruction with multiple fluid levels, air fluid levels, perfect. هدى عباس. Again, bowel obstruction, small bowel obstruction, dilated bowel loops. Here it seems to be like large bowel obstruction with the clue sign. Here the dilated, small or large. It looked like small bowel obstruction. Yeah, more small, because the large should be more than 6, but I think the small bowel more. Again, small bowel obstruction, valvulae convex, dilated, so small bowel obstruction. This one, what is this? So this one is the reduction of pneumatic reduction of with air. You try to reduce the intussusception. So this one intussusception. Large bowel dilatation. This one is very famous in the exams. So small bowel obstruction with left inguinal hernia. The cause is inguinal hernia obstruction. If you bust the inguinal ligament, look below the inguinal ligament. If you find any air, this is the hernia. Small bowel dilatation and the large bowel dilatation, same patient, paralytic ileus. Dilatation, large bowel, small bowel, paralytic ileus. Here is small bowel obstruction. Yes, dilated small bowel. Large bowel is not dilated. Yes, Huda, Ahmed, thank you. Small bowel obstruction. Another picture of small bowel obstruction. Inguinal hernia, small bowel obstruction. Yes. I show you like many cases of small bowel obstruction. Another case, just dilatation with the valvulae convex. You check for any perforation. The same, small bowel obstruction. Small because this is the characteristic of small bowel, that the valvulae continuous from wall to wall, and there is dilatation more than 3 centimeters. And you can see that there is multiple bowel loops. So this is a small bowel obstruction. Again, the same here. You will check for any perforation, and you check for if there is concomitant large bowel obstruction or large bowel dilatation. You see here from side to side, dilated bowel loops. So this one is a small bowel obstruction. Many appearance or many forms of small bowel obstruction. Multiple air fluid levels. Yes. Just before we finish, I want to just show you last thing about the abdomen. I mean that we, at least today, we collect everything about the abdomen. There is one just this one maybe. Yeah, this one we take it. I think we have just to finish with the. Yeah, this one. Just I want to show you more examples of this appearance, last 3-4 minutes. So this one, the colon with thickening in the wall, thumb printing is colitis. Let's show you more. Thumb printing again. This one more obvious. Thumb printing. Thumb printing colitis. Colitis, thumb printing. Colitis, thumb printing. Lead pipe, ulcerative colitis. Lead pipe. Thumb printing. This one is more obvious. Bowel wall thickening. So colitis. Thumb printing. From outside, this patient have contrast. So you have many examples of thumb printing and how you check for colitis. Just I'm checking if I can show you something. So just to check that everything is okay with you. So who is still awoke with us in this session? What is the pathology here? We have about 7 pictures. The radiologist start today who can score all of them. So which pathology is here? You check for 4 checklists: gases, bones, soft tissues, calcifications. Is it difficult? I will show the answer. Acute stage. They electrolysis they don't consider it as acute condition for the exam. And this is enterolithesis, not retro. But I agree with you that there is a finding here, but this is not the important finding. No way. So maybe I start with the most difficult one. You remember the curvilinear shadow when I talked with you that when you find the curvilinear shadow. So the curvilinear of, yes, exactly, the abdominal aortic aneurysm. You find the calcification of the aorta, so abdominal aortic aneurysm. Okay, and here, this one is easy. Bilateral renal calculi. So everyone score it, nice. And this one, colitis with complication, toxic megacolon. Perfect, Ahmed. And this one, you see that there is displaced bowels. There is hepatomegaly. It's a bit distracting because maybe this is, I think, transverse colon, displaced inferiorly. It look like hepatomegaly. Yes, the answer is hepatomegaly. Okay. No, it's not colitis. Left renal calculus. Yes. I like this drawing. Okay. It's good. Okay. Here. No. Yes. And what else? Yes, what else? Free air. I'm searching for free air. Yeah, free air, free air. And there is regular sign. So you have many types of signs here that indicate that this patient have pneumoperitoneum here. So what's this? This is the bowel loops here are displaced inferiorly. So what is this? It could be mass, large mass here. So right, maybe from the liver, maybe from the spleen, because there is displacement down. So at least you can say that there is right upper quadrant mass. Okay. We already show you this. Dilatation. Dilatation. So you are talking about small bowel obstruction. Valvulae. With dilatation of the bowel, you are talking about small bowel obstruction. Now I think it's easy. Valvulae, reach from side to side, then you are talking about small bowel obstruction. If you are not still recognized how to differentiate between small bowel obstruction, large bowel obstruction, just go for Google and write in the search, and you will find many cases, and train yourself because it's very important for the practice and for the exam. Yes, so this one is, yes, colonic obstruction. Which type? I will try to like this as twisting, starting from the, yes, so there is sigmoid volvulus. Sigmoid volvulus starting from the left iliac fossa. Another type of sigmoid volvulus, twisting starts from the left iliac fossa. You can put your thumb, so thumb printing. There is still many cases, but the time I think is late now. So I hope that enjoy. I know that maybe is much questions about how you differentiate and so on. If we can do another session next time for the abdomen, but we can involve something else like chest, or we will see, inshallah. I hope that you enjoy, and if you need any help or question, you can, inshallah, in the group. Have a nice night and enjoy a good sleep, and assalamu alaikum, inshallah. See you.